Good morning, and thank you for joining us today. My name is Bill Graham. I'm the Plan President for Senior Whole Health by Molina Healthcare. I'd like to welcome you to today's virtual panel. I'm proud to host this discussion on behalf of Senior Whole Health and the MolinaCares Accord. MolinaCares is a commitment from Molina Healthcare to building stronger communities by bringing innovative models of care to under-resourced communities. We know that you are busy and appreciate you taking the time today to discuss how the place-based supports, or PBS model, is improving the lives of seniors across the Commonwealth. For the last 20 years, Senior Whole Health has been committed to ensuring our aging population receives the support and the care they need to thrive. Today, our commitment to the PBS model is deeply tied to this mission. By integrating community health and well-being strategies into senior affordable housing sites, we can make a lasting impact on seniors by empowering them with the resources to improve their health outcomes so they can lead healthy, fulfilling lives while remaining in their homes. Nearly 50% of older adults lack the financial resources required to pay for basic necessities, including food, medicine, clothing, and hygiene products. To meet the needs of the senior population, stakeholders from across the healthcare industry and the community must work together to address the unique challenges facing our senior population. Consider just this week a study of people over age 50 led by the Harvard T.H. Chan School of Public Health that found that loneliness may dramatically increase the risk of stroke by over 50%. Senior Whole Health is committed to supporting the needs of these populations. Earlier this year, Senior Whole Health, in collaboration with MolinaCares, announced a $500,000 investment in PBS to help community organizations meet seniors where they are to address concerns over social isolation and other key indicators of health like food and housing insecurity. Building on this commitment, we recently announced a partnership with Hebrew Senior Life to expand the model for older adults at affordable housing sites in Massachusetts with the potential reach of over 1,000 residents. This partnership is supported by 2 grants totaling $300,000 from the Executive Office of Health and Human Services. In addition to serving our communities through various programs and partnerships with community organizations, we also appreciate the opportunity to convene today's discussion on some of the most pressing issues in healthcare across our state, highlighting innovative programs being implemented by individuals on the ground. Before we jump into our panel, I want to introduce our keynote speaker, Emily Cooper, Chief Housing Officer at the Massachusetts Executive Office of Elder Affairs. Emily is a nationally recognized expert with over 20 years' experience helping organizations to access and better utilize housing programs to meet the needs of special populations. At EOEA, she is responsible for helping design agency policy around preserving and expanding housing opportunities for EOEA consumers so that they may age in the community. I am thrilled to share some remarks that Emily prepared to kick off this event.
Hello, my name's Emily Cooper, and I'm the Chief Housing Officer at the Executive Office of Elder Affairs. Thank you for inviting me to speak with you all. I wish I could be with you live, although virtually, to hear the great presentations and discussion. I'd also like to thank Senior Whole Health for putting this event together, and more importantly, for recognizing and elevating the topic of place-based supports. Today, you're going to hear a lot about place-based supports, which is a term that really didn't exist until recently. In fact, we kind of made it up. I consider it a term of art, born of the need to better define these non-clinical services that are made available in apartment buildings, particularly buildings that house older adults, to combat isolation, to address food insecurity, to foster community, and to help older adults more effectively and appropriately use healthcare. The model centers around a resident service coordinator, or RSC, which is a trusted individual who acts as a combination of a family member or concierge who's on site in an apartment building with eyes on residents on a regular basis. Similar to the doorman in New York City, the RSC is an astute observer and might see Joan limping on her way to the mailbox, ask her how she's doing, encourage her to call her doctor, and ultimately help her make the doctor's appointment and figure out the transportation. Being on site, the RSC might notice that Mike, who usually plays checkers in the common room in the afternoon, hasn't been seen in a few days. RSC knows Mike has a history of depression, so they go to his apartment to check in, only to find Mike is feeling really low. So the RSC helps him contact his geriatric support service coordinator to get him reconnected with a behavioral health provider. Because the RSC is embedded in housing, they'll also be connected to the housing maintenance staff, who were recently in Anna's apartment to turn the HVAC unit from heat to AC. While there, the maintenance staff noticed her fridge was bare, and they let the RSC know about this, who then visited Anna with a bag of food and helped her complete an intake for home-delivered meals. The vital importance of place-based supports and the RSCs that oversee them was really magnified during the COVID-19 pandemic, during which RSCs served as the lifeline for vulnerable older adults who were staying home and unable to access community-based services. If you remember, way back when, before vaccines were available, many of these apartment buildings, particularly those filled with older adults, locked their doors to visitors and turned their attention to keeping the building residents safe. According to a study from the Joint Center for Housing Studies at Harvard University, during the pandemic, many of these older adults struggled to meet personal and healthcare needs, obtain food, medication, and supplies, and to deal with the loneliness that resulted from the necessary precautions that were put in place to protect them from the virus. The study found that the RSCs were really the linchpins, as I said, the lifelines, who responded to these problems by helping residents access and use technology, facilitated procurement of anything they needed, and developed new protocols, new programs to help residents cope with isolation. They were really forced to think outside the box. My favorite pandemic innovation came from a senior housing property that created an outdoor movie theater where every resident had a comfy chair placed in its own hula hoop on the lawn to allow for social distancing. Well, the RSC is the key to place-based supports model. These supports are spectrum. So in addition to the resident service coordinators, some buildings may have community activities like those outdoor movies, wellness programming, on-site congregate meals, maybe even an on-site wellness nurse. There's no one model. But studies have shown that even those models that only include a resident service coordinator have an impact on healthcare utilization and costs. A study completed by Leading Age Center for Housing Plus Services and the Lewin Group of over 500 HUD-financed senior affordable housing properties that collectively housed over 44,000 residents found that residents living in housing with an on-site resident service coordinator had significantly lower hospitalization rates than those residents living in housing without a resident service coordinator. Specifically, this study found that just the presence of an RSC was found to decrease the odds of a resident having at least one acute inpatient admission by 18%. Other studies have also shown healthcare savings from place-based supports attributable mainly to the prevention of emergency room visits and hospital admissions. For example, one place-based supports model and subsequent evaluation demonstrated a slower growth of annual Medicare expenditures among residents with access to place-based supports in their apartment building. These savings, estimated to be about $1,100 to $1,500 per individual per year, accrue to Medicare and healthcare payers such as Mass Health Senior Care Options or SCO plans like Senior Whole Health. Our agency, Elder Affairs, is committed to making sure older adults have access to the tools and resources they need to safely and independently age in community. This includes increasing and enhancing place-based supports in senior affordable housing, with an emphasis on the 110,000 subsidized apartments for older adults across the state that are operated by local housing authorities and private housing owners and property managers. These senior affordable housing properties bring together large groups of low-income older adults and offer a unique opportunity for delivering health interventions at a larger scale. In recent years, our agency has expanded the EOEA supportive housing program that provides funding to local Aging Service Access Point agencies, or ASAPs, who hire RSCs and then offer meals and wellness programming in senior affordable housing. In the past 3 years alone, this program has grown almost 50% and now assists over 8,800 residents of senior affordable housing across the state. In addition, and what brings us here today, our agency partnered with Mass Health to award funding to Senior Whole Health and other Mass Health SCO plans to enhance and invest in place-based supports in senior affordable housing and further their efforts to use senior affordable housing as a platform for health. I'm eager to see the great work that Senior Whole Health, their partners, and their peer health insurance plans engage in with this funding and the innovations they pilot in order to sustain the impact. Thanks again for inviting me here today. I wish I could be with you virtually, but in person. But I'm pleased to see how our collective work continues to improve the lives of older adults across the Commonwealth.
Thanks again to Emily for sharing such valuable insights. Now I'm excited to introduce the panelists who will be joining us for today's discussion. Each of the panelists with us today is a leader in their respective fields and is deeply committed to bringing the PBS model to life across Massachusetts. We are honored to have them join us today in what I know will be an engaging discussion. Steve Beauregard is the Executive Director of the New Bedford Housing Authority and has been with the authority since 2001, initially as Director of Leased Housing and then chosen to lead the authority in August of 2010. Under Steve's direction, the New Bedford Housing Authority has been a HUD high performer for both the public and leased housing programs. Steve also has many years of experience working with other local housing authorities and was previously the executive director of the Westport Housing Authority. He is also a graduate of the PHADA Rutgers EDEP program. Kim Brooks is the executive vice president for senior living at Hebrew Senior Life in Boston, Massachusetts. She joined HSL in 2013 as a healthcare professional with over 25 years of experience in the development, delivery, and reimbursement of innovative housing and community-based services for seniors. She oversees the operations of the 6 HSL senior living sites that are home to more than 1,700 residents, including continuing care retirement communities and supportive housing. She is also involved in a number of the organization's emerging business initiatives. Pam Bolorino is the Vice President of Acute Care Services at Child and Family Services. She has worked in the field of social work for 20+ years in various clinical support and leadership roles. In addition to her role as the ESP Director at Child and Family Services for the last 5 years, her prior experience includes working as the Clinical Director for Pembroke Hospital, as well as the Social Work Manager at Beth Israel Hospital, Plymouth, where she worked for over 7 years. Cheryl Shondek is the Chief Operating Officer at the Greater Boston Food Bank, overseeing the acquisition, distribution of all healthy food, as well as managing food procurement, the entire warehouse operation, which I have to say is really impressive, having had the chance to be there and help fill boxes, building, facilities, budgets, transportation, logistics, inventory teams, volunteers, and community impact, including all partner agencies. Since joining GBFB, she and her team have grown the food bank's acquisition by more than 95% and increased the volume of fresh food for clients in Eastern Massachusetts. Thank you to all of our panelists for taking time with us today for this important discussion. Steve, I'm going to start with you. The PBS model is bringing services directly to seniors at their doorsteps and senior affordable housing facilities, including several in the New Bedford Housing Authority portfolio. What are senior affordable housing sites and what are some of the unique needs of your residents?
Thank you, Bill, for hosting this for us. I think it's going to be very informative. We have 3 sites that are currently in use with PBS. We're very excited about New Bedford Hotel, Bow Vista, and Trip Towers, which is our largest with about 202 units. We have thousands of elderly residents, needless to say. Many of them have been with us for years and years. We have one that's been with us. I think he's been with us 59 years. We have another woman that's been with us about 65 years. Came in I think 1965. So, the need that we're seeing now is so much more greater than it ever has been, whether it be mental health, be isolation post-COVID, medical care. We're receiving people coming in now that supposedly have support services that don't have adequate support services once they get in, which I'll talk about a little bit more as we move along. So programs like the PBS are so invaluable to an organization like the Bedford Housing Authority. We have more and more residents aging in place. They become very, very difficult for us to manage. I just can't say enough for the services that this program is providing.
Thanks, Steve. Kim, I'm going to turn to you next. Senior Whole Health's approach to place-based supports is based on Hebrew Senior Life's Right Care, Right Place, Right Time, or R3 model. Can you tell us a little bit about R3 and the history of how it was developed?
Thank you, Bill. I would be happy to. So 4 of our communities are affordable service-enriched senior housing, and they're home to about 1,000 older adults. And that's the basis of our R3 program. So for us, R3 means, or is a program of, it's replicable, sustainable, service-enriched housing, focused on keeping people as independent as possible for as long as possible, and reducing healthcare costs and long-term care costs. So just a couple of the foundational principles of the model. One, you heard Emily talk about eyes on. It's a big part of it. It's leveraging the really small senior housing, small but mighty senior housing team, maintenance, front desk, resident services, to identify what's happening with people and to know what to do with that information. Another is understanding what matters to people, helping older adults set goals and reach those goals, which, as you can imagine, have much broader implications than just that individual goal. And then also proactive outreach. So not just waiting for a crisis to happen or waiting for somebody who happens to come and say they need something, proactively reaching out to everybody who lives in the building, developing relationships with people and understanding what their needs and wants might be. So our 3 program began in 2017 with some funding from the Health Policy Commission. We embedded a wellness coordinator and a wellness nurse into 7 affordable housing sites, serving just a cohort of 400 people. And while we were working on the model that I just described and all those proactive supports, we were also very focused on integration and the integration with the health plans, the aging service access points, anybody who is part of the care team for those residents. And so those partnerships, and like the one that we've now developed with Senior Whole Health, have allowed us to grow the program. We're now in 15 sites and we're serving more than 2,000 people, and we continue to grow it. So one of the biggest areas that we're focused on is the sustainability component, and we're working on that through things like the expansion of Medicaid through waivers, by the investment and partnership of the health plans and actually paying for some of the place-based supports. And then also making sure that we have the value of the services built into the rental subsidies that we get for people. Hopefully that gives you a good summary of the program.
Great, thanks, Kim. Pam, Child and Family Services role in this partnership model focuses on crisis intervention. What are some of the crises that seniors can experience?
So thank you so much for having me here. I think some people think of crisis and they automatically think that somebody has to be in crisis to utilize our service. Our goal is to intervene before someone actually goes into crisis. That's why we have the word intervention in our MCI. So some of the areas that I think that mobile crisis can be really helpful and that seniors tend to often encounter as they're aging is health crisis, right? So a lot of times they have chronic illnesses or a sudden illness or an injury. They can also have a chronic disease that exacerbates. So those are things that some people think, well, that's medical, so why is crisis involved? Because it actually can impact somebody's emotion. If they're getting news about, some type of a disease that they've been diagnosed with, that could be a lot for them to process. So we're able to at least intervene and guide them and give them the support that they need in that initial contact. A lot of times there's accidents that happen as people age. One of the things I've noticed, having worked with elderly for so many years, and haven't worked in an acute hospital setting, is falls. Falls are really, really significant for the elders. And with falls, not only does it come injuries, but it also comes that inability to walk or do things the way you used to do before. So you're having to adjust to this whole new way of walking through your home, or the way that you used to go to the bathroom cannot be that same way anymore, and that you might need certain things in that bathroom to help you. And that's that loss of independence, which we can help a lot with, and really sit with them and get them to understand that it's normal to feel this way, and we're going to be able to support them. Abuse and neglect is, I worked many years in child protective services when I first started social work. So having gone into the field and interacting with elders, I was shocked at how much abuse and neglect actually happens with our elders. And I really think it's underreported. But there is a lot of abuse and neglect that happens. And a lot of times the elder are afraid to actually talk about it. And abuse and neglect is not just physical abuse, emotional abuse, sexual abuse. There's a lot of financial exploitation that happens. Self-neglect is also another piece that we see a lot. And we've been working with New Bedford Police for a long time, and we often would go to elderly homes because there would be a lot of self-neglect, which often can also be correlated with some type of a mental health issue as well. Housing issues, right? If they're struggling to meet ends, make ends meet, and they have loss of housing or feeling unsafe in their living conditions or potentially being homeless, those are some of the things that we can help. We're not long-term, we're very short-term, we're an intervention, but our goal is to set them up with someone that can then take over and assist them in what their needs are. So housing's not our specialty, but we can connect them with those that can help them. Social isolation, right? What happens as you're aging? People, you end up with folks that you used to be with all the time and interact all the time, and maybe you don't see them now. People are passing away, or they're moving away, and all of a sudden now you're finding yourself very lonely with the lack of support that you need. A death of a spouse or a family member can be significant impact on someone's well-being. We also realize there's a lot of financial crisis that happens with the elderly, and there could be their inability to just pay for their basic needs like food, utilities, medications. Also a lot of like scams, right? Financial scams that could potentially happen, and they're so vulnerable that they could be taken advantage of. And we often, when we're meeting with somebody who we're trying to intervene on, we find that it's not just what they're coming in feeling like, I haven't slept in so long. And then you find out why. You find out why they haven't slept. There's all these things that are happening, and you're like, this makes sense, right? And then there's also like the legal aspect of it. People don't realize, but often the elderly need to get guardians or power of attorneys, or you need to be proactively helping them with getting, a healthcare proxy before it's too late and they can't name somebody that they know because they're not able to. And with that comes a lot of other things, right? A lot of like, what do I do? Who do I assign this to? I don't have anyone in my life that I can name. And that could be a stressor for someone to not know who to talk to and guide them. So there's a multitude of things that I feel that is really not just recognized, but underreported when it comes to our elderly. So I greatly appreciate this because I think that is a significant piece of this. And along with mental health, we also have the piece of substance abuse. And often people don't realize how much substance abuse actually occurs with our elderly, and they usually go side by side. So yes, thank you.
Right. Cheryl, I understand the Greater Boston Food Bank recently released a study on food insecurity. What were some of your findings about the state of hunger in Massachusetts, especially among seniors? Are there any unique needs that seniors have?
Thank you again, Bill, for hosting this event, and thank you for all the work that you do, and especially to the other panelists. Just hearing the three of you start off, I'm learning so much. And your support of this special mission is just overwhelming. As you know, the Greater Boston Food Bank is the largest hunger relief organization in New England. And yes, we just completed our 4th annual statewide study focusing on food insecurity. And this year, we had the opportunity to expand the survey with some new questions to go take a deeper dive and learn more about food access and barriers across cultural, socioeconomic, and geographic boundaries. And something very interesting that we found was a consistent theme across all populations was the impact of food insecurity, especially on seniors. It is increasingly high, and we're finding a lot of what you all have said, facing the physical challenge, they have difficulty, and they're telling us, of accessing the healthy food that they need to thrive. Our study unfortunately found that 1 in 5 seniors are considered food insecure. That's about 20% of the senior population in Massachusetts. A state as prosperous as ours, that is a staggering statistic that we need to improve upon. We need to do a better job making sure that these seniors have what they need to be food secure. Many of the seniors that we surveyed also expressed concern about rising food costs. We've seen that. That's added stress about trying to figure out where their next meal is coming from. And we also found that they face those unique challenges in accessing the resources because of barriers like adequate transportation and also being on a fixed income. They have more instances of chronic health conditions. They can't get to the grocery store. They can't get to a free food distribution site, and they're telling us the challenges that they're facing. So we all know, and we can all agree, that access to healthy food is a basic human right. And collaboratively, we need to do a better job to end hunger in Massachusetts, especially for the senior population.
Now, Steve, I'm curious to learn more about how the integration of community partnerships has supported your work to bring wraparound care and education to your residents. Can you speak to some of the services being offered at your facilities and the impact you are seeing it have?
Well, with your services and with your help, we've now have a team on hand that helps the residents with physical, mental, and social well-being. We had some of that in the past, but not to the extent that we have today. It means accessing, excuse me, they have an access to a network that will help them take charge of their well-being. The program assists in a number of ways, including dealing with their primary care physicians, doctor's appointments, transportation, treatment plans, translation and interpretive services. We now have a full-fledged breakfast and lunch program at 2 of our sites, Trip Towers and Boa Vista, through the program. It helps address, as Cheryl just said, food insecurities, where we're able to feed them now 2 meals a day. Allows for socialization, which Pam talked about, who we do work with Cheryl and with Pam on a regular basis, and talked about the isolation. So now they can come downstairs as a purpose. They sit with other residents, they have conversations. And just as importantly is, if they don't show up for lunch or breakfast, we then go and find out why they're not there and whether they've just, left the building for the day with family or whether they've taken ill in the unit and just can't come out. So that has a number of benefits to us as well. And the PBS model is a component to address mental health issues, which seems to have risen exponentially for whatever reason. I don't know whether it's COVID, post-COVID, what's going on. But the mental health issues that we are dealing with now have become, epidemic for us. So residents now have access to mental health issues through the program, mental health crisis counselors through the program. And although the program is relatively new to us, we are, in feet first and think that the results are going to be astounding.
Thanks, Steve. Kim, core to R3 is embedding resident service coordinators and nurses into senior affordable housing sites, as well as close coordination with other care managers involved in residents' care. What are some of the outcomes you're seeing by integrating this wellness support into facilities, and how do you hope to continue building this innovative model?
So I referenced earlier our demonstration program, and we were fortunate to have that evaluated in a full research study by the Leading Age Long-Term Services and Support Center at UMass Boston. They did a series of analysis pre and post study, also a study of our intervention group against comparison group, and did quantitative and qualitative research on that model. So we couldn't have been happier with the results that we got from that study. I'll just share a couple of the outcomes with you here just to give you a sense of the health outcomes. For example, we had a 16% decline in hospital admission rate compared to a 6% increase for the comparison sites. And as it relates to hospital length of stay, we had a 12% decrease compared to a 20% increase. And then the last just stat I'll give you is on our trips to the emergency room, our intervention group had an 18% decrease pre and post. So as you can imagine, all these factors just reducing healthcare costs and really helping people stay home, which is where they want to be. So the other thing that we learned through the research was that people were really satisfied with the program. They felt so happy about having just that sense of security, safety, knowing someone was there for them. And particularly we had one person, for example, give a quote about, any medical or otherwise problem that I have, I know I have someone to go to. I know where to go and who to talk to. I just think that makes such a difference when something does occur. So It is certainly my hope that with these kind of outcomes, that those are noteworthy to managed care plans, as they have been to senior whole health. And that with the flexibility of Medicare and Medicaid dollars that plans have and how they can invest those, that we can do more of these partnerships and just continue to invest in the place-based supports, whether it's with us or other place-based support providers like us, so that we can continue to expand on the benefits and the long-term benefits that we're already seeing.
Right. Pam, what are some of the ways Child and Family Services is bringing on-site crisis intervention support to seniors? And how has this programming impacted outcomes for the seniors you serve?
So as a mobile crisis intervention team, we've been around for a really, really long time, and we're 24/7. We never close, holidays, you name it. And we always have clinicians on site at our, we have 3 different sites. We have a Plymouth site, New Bedford, and Fall River, but our New Bedford site being the largest, and where we're currently really focusing on the housing piece and how to support these individuals. So what's come of this is that we've been able to embed a clinician in New Bedford housing. They cover 3 different sites. They have a schedule. Staff know what folks in housing know exactly what days she's there, the hours she's there. And the way that it works is that, like, when we get a call over at Mobile Crisis that someone in housing is in need of an intervention, we just let our clinician that's there know, and then they'll dispatch to whichever housing the individual is at. And what they're able to do is really just gather information. As a mobile crisis team, we're not there to do therapy or things like that. We're there to say what is going on and how can we best help this individual stay in the community and not go to a hospital. That is our goal. So the individual will gather as much information as possible from the person that they're serving, from the collaterals, and ultimately make a decision: how can we support this individual to stay in their residence? We know for a fact that individuals that stay within their own residence around people that they're familiar with, that they feel more supported, they have a better outcome when it comes to treatment of their mental health versus going into an emergency room or to an inpatient psychiatric facility. So the cool thing too about mobile crisis is that we also have the ability, which started when we became a CBHC last year, when they changed the model and the specifications for us, that if an individual does need a higher level of care, if they do require to go to an inpatient psychiatric facility because they're unsafe for themselves and others, we can actually send them directly from our crisis site right to an inpatient facility without ever stepping foot in an emergency room. So we have up to 23 hours to actually find a facility for someone and place them there within 23 hours, and they never have to step foot in the emergency room. So that's unique, that's new. And we've had a huge success in that in New Bedford when it comes to what we call direct admits. But truly, the fact that we can deploy clinicians on site from our crisis, if our clinician on site is busy, we'll just send somebody right from the office and be able to meet those individuals immediately. We respond in less than an hour to really find out what is happening and what can we do to support you and to get you to a better place, so that we can minimize what it is that's stressing this individual out, or what the symptoms are that they're experiencing in that moment.
Thanks, Pam. Cheryl, can you tell us a bit more about your work with Senior Whole Health and the gaps it is helping to bridge in food security among seniors?
Yes, absolutely. Senior Whole Health has been such a great partner of ours for many years. And you folks all understand the challenges that older adults are facing, and you have opened up new doors for us to help us expand our network and our reach. Through a grant last year by the Place-Based Supports Initiative, PBS, you folks are funding for a full year and enhancing our mobile market with the New Bedford Housing Authority. And we are serving the seniors in that community because of this collaborative effort. For those of you that may or may not know, this mobile market provides amazing fresh produce to the seniors in the community. Items like plantains, mangoes, bananas, potatoes, tomatoes, and so many other nutritious items. And quite frankly, I equate this program to the teamwork that we just saw exhibited by our Boston Celtics. This is a team effort supporting senior whole health employees. It's amazing what they do. They volunteer their time at this monthly market alongside many, many members of the Housing Authority. Employees working together to support the senior population. It's a great model. It's a private-public partnership that meets people where they are with real, authentic intention in trying to mandate that no senior in that area is being left without access to healthy food. So thank you for the work that you're doing to help support that community.
Thanks, Cheryl. And, this has really been a really valuable partnership for us, both in terms of serving the community, but creating opportunities for our staff, who I know find it so meaningful to be out volunteering, and would love to be compared to our world champion Celtics as we continue to celebrate here. So I think we can all agree that improving health outcomes for Massachusetts seniors goes beyond providing traditional medical services. And one of the most pressing issues facing seniors is social isolation, which we know is directly tied to health outcomes. So my last question before we get to the Q&A from the audience is actually I'm gonna pose it to each of you. And that's, how is the PBS model addressing needs around social isolation? Are there other ways you think providers and other sectors of the healthcare field can come together to work on this important issue? And Kim, I'll start with you.
Okay. So you heard me talk about proactive approach and building trusting relationships. Certainly those things I think are having a huge impact in breaking down that isolation barrier. And then, we also are, through assessment and individual work one-on-one with people, identifying needs and able to partner them up with the resources they need that we can't provide directly. And to Cheryl's point on, it's a team sport, really making sure that we're leveraging all those other resources that are out in the community. I guess the only other thing I'd say is, just from a place-based supports model standpoint, because we know what's happening with the whole population that's living in that one building, we can get really efficient about deploying resources, or about going to our partners to say, here's where you might want to invest, because here's where we know people are struggling or what the challenges are.
Right. Thanks. Steve, can you weigh in on this?
Yeah, I think, I know the question was on isolation, but I think there's a couple of other issues that if I could just very quickly address, and then I'll segue into the isolation. Plain and simple, this program is invaluable to the Housing Authority. We are taking in many residents that we are told have services when they're coming to us, and we're finding out that they don't have any services, or the services that they are receiving are completely inadequate. Staff is reporting, residents that are sitting in wheelchairs and feces at the end of the day because there's nobody coming in and checking on them. There's no family members. And this is where, this program really comes in to assist us. We have others that are, in wheelchairs that can't get into bed at night. And it's really, you talk about mental health with the residents. We have a big problem right now with mental health with staff. They're property managers, they're not social workers. And we're asking my property staff to become social workers in dealing with this. I mean, you have to have empathy, right? In what we do, all of us that are part of this webinar this morning. And you can't just turn your back and leave somebody in a wheelchair that can't go to bed, and they're going back after hours, and they're putting them down, and they're getting them up in the morning so that they can have some semblance of life. And we were doing this for years now because the services weren't there. So, and it's all, gets into, again, all the part of the isolation and these people being alone and not having, their carers taken care of. And all of this has become very challenging. They're aging in place. So aging in place means we have more and more people dying in place. So we're doing welfare checks, and then you go in there and there's somebody laying in the bed or the floor who's passed away. You talk about the mental psyche of the property managers. I mean, that's not a good scenario for people to walk in on a regular basis, seeing people that are deceased. And so, you're going to have it in the people the social workers that we're now sending in. But all this home-based scenarios have caused us issues that we never had to deal with in the past. You know, when you reach a certain point, you become immobilized, you know, you went to a nursing home, you went to a, you know, extended care facility. They're not anymore. They're ours, and they're ours long-term. As I said earlier, we have people here that are 50+ years living in public housing. You know, so the isolation, again, very important to be addressed. But you know, the mental health issues, the care and needs that they're experiencing that everybody here has talked about is so relatively important, which is why we have come in, as I said earlier, feet first on this program.
Thanks, Steve. Some really, really sobering thoughts and perspective directly from the communities that we serve. Pam, I'm gonna turn to you to add to this conversation on social
Yeah,
isolation.
definitely, for sure. I start to think of like the integrated care teams, right? Folks that have that contact with these individuals, like primary care doctors, collaborating with not just healthcare providers, primary care, mental health professionals, social workers. You can work together and identify the social isolated seniors and develop like a comprehensive plan. What can we do to support this individual so they're not feeling so isolated? And often as a mobile crisis intervention team, we're able to identify some of those things that when we're meeting with individuals to realize like they haven't had a visit in a really long time from anyone. They're often sitting at home by themselves watching TV with no interaction from others. Engaging community health workers, employing community health workers to act as liaisons between the healthcare providers and seniors to be able to identify the isolation and really receive more of like a holistic care and support type of approach. Encouraging them to go to, come out and have dinner in the dining hall instead of in their room. Really trying to identify what senior health centers out there that they can go to, like a day program and be able to socialize with others. And I really think awareness is a big thing. So like educational campaigns, raising awareness about the impact of social isolation on seniors' health and encouraging like our community members to engage with and support their elderly neighbors. I know I can speak from personal experience. I have an elderly neighbor that lives like 2 houses down from me, and I know her by name. I know her so well. I don't see her often, and when I don't see her often, I'll often walk by and knock on her door, and I'll say, "Rita, how are you?" And she's like, "Oh, thank you for stopping by, Pam," because I know she lives alone. And so if I don't see her for a little bit, I'm like, "Oh, I wonder if Rita's okay." So I think just those little things can go such a long way, right? Oh, I haven't seen this resident in over a week. Maybe we should check in on them. Maybe they received bad news and they're sitting in their room by themselves and don't want to talk to anyone. But now somebody knocked and checked in on them and they're more willing to have a conversation. So it's little things that can actually make such a significant difference in someone's life.
Thanks, Pam. And Cheryl, we'll wrap this question up with you.
Sure. So again, our core competency is distributing food. And unfortunately, we find that food insecurity in Massachusetts is continuing at this disturbingly high level. And I think a theme that we've heard today is that it's imperative that we all work together to meet the needs of our neighbors, especially the seniors, because they're facing so many other challenges. These are our parents, our grandparents, and just like everyone else, they have the right to regular access of healthy food. And I can't say enough about the PBS model because it's empowering all the residents with that particular segment and opportunity to thrive, to get nutritious produce every month. But I feel we have to do more. We clearly have to do more. We're not doing enough to meet the need. So we have to expand the community, and we need to listen to this diverse population that we are serving. But I personally feel confident with that combination of collaboration, expanding the community partnership, listening, we will make a positive impact in the Commonwealth for our seniors. I'm overwhelmed at the support and the work that you all do. So again, I just want to thank you for inviting us to this important conversation.
Thanks, Cheryl. And thanks to all of our panelists for such an insightful conversation. It is great to hear directly from community leaders on the front lines making a difference in the lives of our neighbors every day. As our panelists have addressed, by integrating the PBS model into senior affordable housing sites, we can address social determinants of health like food insecurity while also bringing much needed education directly to seniors. by bringing resources directly to seniors' doorsteps, we can empower them with the tools to thrive while aging in their own homes. Now I'd like to open it up for Q&A. I know folks have started to drop questions into the chat, and I encourage people to continue to do so. So I'm going to start with this first question, and that's, what are some of the challenges that you find most difficult to overcome in reaching populations who need your services, and how is PBS helping to overcome those challenges? And whoever would like to jump in and start.
I can comment on it real quick. I think the biggest dilemma that we have is a lot of the people that we deal with have had mostly the female and the children have had a number of people come into their lives and go out of their lives, right? Fathers come and go, boyfriends and husbands come and go. So it's a challenge for us to get their trust, that we're going to be with them and listen to their stories and help them for what we're talking about today, long term. That we're not going to be the husband or the father or the boyfriend that just comes and goes and listens to you and then passes you off and see you later. Once you develop that trust, then we can make significant impact. And it takes time. It's not going to happen overnight. They're not just going to come in and sit down and give you their whole life story, not knowing who you are. But once they get an understanding of what the programs are, all of them, all the programs that we're doing, once they understand what we're doing and what it's all about, and have a sense that you're there to help them, then the benefits are just, they speak for themselves.
I think if I can just add too, I think that, the word mental health, like when we're coming in to see them, right, it could be scary. They're hearing mental health, mobile crisis intervention, they hear the word crisis, they're like, why is this person here? And, one of the things that we try really hard to do is to minimize their anxiety about why we're there and come in with a non-threatening approach. And, coming from the practice of strength-based as a social worker, right, teaching my staff to also take that approach to be more strength-based, right? Focus on the things that you can engage the individual with to really determine what their safety is, right? So I think that that's a big factor, is the frightness of the word crisis, minimizing that as much as possible to get them comfortable enough to have a discussion with you so that you're able to make a decision on what's best for them and their next steps.
And then I just briefly build on a little bit about what Steve talked about. I think you have older adults who are, they have a lot of people coming in and out of their lives. They may be getting calls, in addition to all of their personal relationships, from a care manager or a sporadic visit with their primary care physician or other specialists. They're trying to access all different things. Having that one consistent thread of a very small team that knows them and kind of is with them in the place where they spend most of their time and can help pull all that together, I think really helping them navigate and make sure that they are getting everything that they want and need, and just supporting that in a holistic way.
Yeah, and I completely agree with everything that you folks have said. You clearly are the experts. For us, I think one of the biggest barriers is that transportation. And similar to what Pam said about training your team, dignity and respect. These folks may never have had to go to a food pantry throughout their working career. Now they're seniors, they're elder. They've come across a crisis. Their family has come across a crisis. They're taking care of their grandchildren, and they now have to go to a food pantry, and that's foreign to them. So we want to try to make it as welcoming and open as inviting, and inviting as possible, and teaching, coaching, training the staff to say it's okay. It's incredibly challenging. And I think, Pam, you had also mentioned, you check on one of your elderly neighbors. I'm very fortunate that through my religious church community, I visit the elderly on Sundays, and I think I get more out of it than they do. They are an inspiration to me, even though when you see them, sometimes you're the only person that they have seen for that week. But it's just overwhelming. So again, I just want to applaud you folks for all the work that you're doing.
Thanks. Another question, and a little more future facing. How do all of you see the PBS model continuing to evolve, and where do you see opportunities for growth to expand the reach and impact of these types of programs?
I know I can answer our piece of it. We're very new to housing with our mobile crisis is not new to us, but you know, with the support of Senior Whole Health and New Bedford Housing, we've incorporated this clinician into New Bedford Housing, and it's just the beginning. We're just really getting folks there to understand who we are and what we do. So it's so grassroots for individuals that have never had an interaction with us. So I can only see it getting bigger and bigger. And often this, I think of it just like our police co-response program. We started with one person and we have 8 now. And to me, this is similar, right? You start with one, and when people realize like, wow, this is actually really good, I can really utilize, and then you start to see it growing and adding more individuals to it because people find the need and the benefits of it.
And I think from our standpoint, I mean, the work that we witnessed Steve do, we would love to clone the group, you know, your whole entire team, Bill, and expand to as many other cities and towns where it makes sense. And that's clearly across the Commonwealth. We operate in 190 cities and towns, and we're open to having any conversation if anyone wants to continue with this partnership, because we have seen positive results for the clients in that community.
I think one of the biggest challenges we see with the place-based service model, you know, if we have 100 or a couple hundred people living under one roof and we can efficiently deploy all these resources and coordinate services for people, it becomes really challenging when you're trying to couple together the payment mechanism for that, right? So you have all these people with different health plans, different coverages, different, you know, services that they are eligible for. And so kind of getting everybody to get into this together and figuring out how we can cobble together the resource component of it so that we can do the work efficiently and effectively. And just to your question on where could we go from here? I mean, I could certainly see taking the place-based service model, when we think of housing as the place, and maybe expanding it so that it becomes a little bit, that's the hub. And you could actually draw the circle a little bit bigger, and we could even, you know, leverage that further to reach people who live in the neighboring community as well.
Yeah, one of the issues that we're experiencing now is that we're seeing people coming into housing that we never would have expected to see, say, 5 years ago. You might have in the Boston market because they've been facing the high rent issues up there a lot longer than we have here. But New Bedford is now facing that. So we've had people that, you know, have been living in their apartments, paying $500, $600, maybe $700, earning $980,000 in Social Security benefits, and have been able to survive. Maybe with some help with some family and friends, they've been able to make it work. And now they've reached a point where, you know, that building is now selling for $500,000 or $600,000. The rent went from, you know, $500 or $600 to $1,200 or $1,300. They're only making $900. It's not working. And so now they're coming in and, you know, they're applying for housing and they're embarrassed by that. So we're dealing with some of that. And then when they do get in, they're not used to receiving services. They've been self-sufficient on their own. Maybe they had Meals on Wheels delivering some food to them. But now we're providing an array of services to them and trying to bring them into some of that is, you know, a lot of them are just embarrassed by it, you know. And it's a tough clientele for us to deal with right now.
Thank you. And I know we're coming up on the top of the hour, which has gone really quickly today. So first, Kim, Cheryl, Pam, Steve, thank you so much, both for being part of our conversation today, but even more importantly, being partners with us as we continue to evolve these programs and really help serve the seniors in our community. And to our audience, I want to thank you all for taking the time to be online today. If you'd like to learn more about the work that Senior Whole Health and other organizations are doing in this space with place-based services, you can visit our website at molinacares.com/Massachusetts. And again, thank you to everyone. And I hope folks have a really great afternoon. Thank you.
Thanks, Bill.
Thank you so
Thank you.
much.